Welcome to Imaging AI in Practice. I am Selena Nahyun Jo from University of Texas Medical Branch at Galveston.
Alicia Dami from Stanford University, and
Albert Zhao, and I'm a third-year resident at Brigham and Women's Hospital in Boston.
We will walk you through a clinical scenario of two patients, the first of which comes into the ED for left-sided weakness. Then we will follow our second patient in the outpatient setting. For the purpose of the demo, the images may not line up perfectly because they're actually from different patients. All of you should recognize this as a PACS system. The demo will focus on the system which you're used to working every day. In this case, we're focusing on Visage 7 Enterprise Imaging Platform. Our patient, John, presents to the ED after waking up with left-sided weakness. His ED doctor orders a head CT, portable MR, and chest radiograph as a stroke protocol. The image is acquired and sent to Visage PACS for storage. The study is also sent to GE Algorithm Orchestrator, which acts as a traffic cop and distributes the study to the appropriate AI algorithm. The chest radiograph in this case is sent to Cura AI QXR. The radiologist sees the chest X-ray comes up in the Red AI Nexus work list. The radiologist notices that the study has been prioritized to the top of the list and marked with a flag suggesting critical findings. We can see here that AI results are available for chest radiograph. When the radiologist clicks on the AI findings icon, the Phobia Extreme AI Cockpit Viewer is launched. We can review the AI results from Cura AI QXR tool through Phobia Extreme AI Cockpit. John's chest radiograph shows a large cavitary mass. The Cura AI QXR tool correctly identifies cavitary lesions that led to prioritization. The radiologist can either accept, reject, and then dictate the final report accordingly. The result that radiologists approve shows on the final DICOM and are also populated in the reporting system. The ED physician later orders a chest CT, which confirms the finding, and unfortunately, the final pathology reveals a lung cancer.
And so that brings us to a close for our thoracic imaging for our patient, and we'll move on to the clinical symptoms that brought him to the ED in the first place, his left-sided weakness. So as a result of this, of course, we're going to get some neuroimaging, starting with our hyperfine swoop MR producing a brain MR. So the hyperfine swoop is always available on standby in the ED as a portable system and actually gets to John's room before he gets a chance to be wheeled to CT. And the cool thing about our hyperfine is that it is a low field strength of 64 millitesla, much less than the typical 1.5 or 3 Tesla scanners that we are used to. So thus safe to be used in a patient's room with other medical devices, ventilators, poles, medications, visitors, staff. And we obtain in this clinical scenario a non-contrast T1, T2, DWI, FLAIR, and ADC images as part of our stroke protocol. Again, before we've even looked at the images, Rad AI Nexus receives the AI result from the algorithm that will be analyzing our brain MRI from Cerebru, which has detected infarct, and his study is already prioritized to the top of the work list, again, expediting care for the patients that might have emergent findings on their imaging. So the algorithm, as mentioned, is Cerebru's Apollo software, which is a tool on the Swoop MR and detects the infarct on DWI and FLAIR, and as a result, generates a DICOM segmentation object that can be viewed on the Visage PACS. We can see the region of interest in the area of infarct. If the radiologist agrees that this is indeed acute infarct, they can accept, reject, or modify and dictate the report accordingly.
Let's move on to the outpatient setting. John's friend David presents to his PCP for multiple sclerosis follow-up. Because his friend John was diagnosed with lung cancer, and since they were both heavy smokers, David decides to enroll in low-dose lung cancer screening. If you're a resident or have ever been a resident before, protocoling isn't the most exciting work for us. Here is what AI can offer to this tedious job. As soon as David's PCP orders a low-dose screening chest CT, GE Intelligent Protocoling Engine receives information for the EMR via FHIR. This includes the medical, social, surgical, family, medication history, or even contrast allergy. It uses the AI algorithm to integrate long-term heavy smoking history and the order request to suggest protocols to the radiologist. As a result, a low-dose lung CT without contrast was suggested and selected by the radiologist. The images are acquired and again sent to Visage PACS for storage and GE AI Orchestrator, which routes the study to Cura AI QCT tool. The Cura AI QCT has detected 2 lung nodules. Results are viewed through Fovea AI Cockpit Viewer. Each lung nodule is listed with size, location, and characteristics, and the radiologist can check each one to accept, reject, or modify. The radiologist can change the size or contour of the nodule, then it will automatically compare to the prior and calculate the doubling time. After confirming or rejecting all the findings, the radiologist exports the result to Smart Reporting Smart Reports. We can see the information regarding nodule location, size, shape, margins, and composition automatically populated into the report. The radiologist is then finished dictating the remainder of the study. Because the AI results are coded in RADLEX lexicon and other coding systems, the AI results are easily and automatically populated into the report template. Again, none of these measurements or observations were dictated by the interpreting radiologist. You may have noticed that all of these different applications open correctly on the same patient. This is possible using FHIRcast. FHIRcast is a standard that synchronizes clinical applications, such as EHR, PACS, reporting systems, or AI tools, to a given study or a patient. It allows different applications to look at the same patient securely. The upcoming versions of the FHIRcast will also enable the exchange of measurements or AI findings. Because the AI results are coded in RADLEX lexicon and other coding systems, the AI results are easily and automatically populated into the report template. Again, none of these measurements or observations were dictated by the interpreting radiologist. Also note that although the AI algorithm identified multiple findings that were presented to the radiologist on PACS, only a subset of those mapped into the final report and presented to the ordering physician in the report, according to the specifications provided by radelement.org Common Data Elements.
Back to David. His PCP also ordered an MRI for MS follow-up. The order is subsequently protocoled by the GE Intelligent Protocoling Engine. In this case, a brain MRI with and without contrast and spine with and without contrast is suggested. These images are acquired and sent to the Visage PACS for storage and GE AI Orchestrator, which routes the study to the Siemens AI RAD Companion tool. The Siemens AI RAD Companion is AI for brain MR that has 2 applications. 1. Brain volumetry and morphometry, which is a segmentation of brain structures, volume computation, and comparison to age-matched normative range. And 2, white matter hyperdensity, MS lesions, detection and segmentation, count, and volume calculation. On David's MR, the Siemens AI RAD Companion tool has detected white matter lesions on FLAIR consistent with multiple sclerosis. Additionally, the most recent brain MR is automatically compared to David's prior MRs. AI results can be presented in 2 ways, SR and SC. If the radiologist could accept or reject the AI findings, this is called DICOM SR, which stands for Structured Reporting. In contrast, in this case, the findings are automatically sent to the DICOM as images, which cannot be edited or changed by the radiologist. This is called secondary capture, DICOM SC. Typing in numeric results in AI findings is a tedious job for the radiologists, but here the values are automatically sent to the Smart Reporting Smart Reports, which then pre-populates the brain volumetry and white matter lesions. The report is now sent to Qvera Interface Engine, where it can be distributed to the EHR and other systems. Quick aside here about Qvera. Many people know that these systems speak standards like DICOM, HL7, and FHIR. The Qvera Interface Engine acts as a translator between these standards to ensure that all systems can communicate effectively and makes everything just work. For example, Qvera can convert DICOM SR results into FHIR, so the data is understood in both PACS and EMR. Thanks to the interoperability, the radiologist is able to plug in the results in seconds and finish dictating the remainder of the study.
As a conclusion, we hope you consider the following takeaways. The architecture of overall system for your hospital is critical. Requiring international standards such as IHE, DICOM, HL7, or FHIR will enable interoperability. Requiring structured, coded semantic systems such as RADLEX, LONIC, and SNOMED will make the AI and other data flow through your system. You need to ask all of these in every RFP for every system. Benefits shown in these specific demonstrations include prioritization of scans with abnormal findings, including lung lesions on the chest radiograph or stroke. Measure and segment FLAIR DWI mismatch or multiple sclerosis plaques. Automatically detect, measure, and compare the small lesions such as MS plaque or lung nodules. But all of these results are reviewed and verified by radiologists through AI Viewer. AI and interoperability not only assists in diagnosis, but also allows to auto-populate templates and inputs the data into the report, and automate protocoling by collecting and analyzing the EMR data.